each other with every step we take. Through the years, through the tears, we'll rise above all our fears. No matter what comes our way, I'll stand by you every single day. Through every challenge, every fight,
in honor of traditions and ceremonies that we as a community value quite deeply, may I kindly request you all to rise in recognition of the esteemed members gracing today's proceedings as they make their much awaited entrance as part of the ceremonial procession. We extend a heartfelt welcome to our guests of honor and the members of the head table. Your presence adds great significance to this occasion. Please be seated.
Distinguished guests, ladies and gentlemen, and all present here today. Once again, a very good evening to you all. It is our privilege to warmly welcome you all to the inauguration ceremony and the KSM oration of the annual academic sessions of the Kandy Society of Medicine for the year 2026.
The Kandy Society of Medicine has been a preeminent leader in the field of medicine and healthcare in our beloved island for more than 60 years. Our profound contributions have spanned several key areas: advancing the continuum medical education of professionals and the public, promoting vital health research, and cultivating a strong, cohesive community among health personnel.
This evening, we stand at the threshold of an occasion that serves as a testament to our enduring commitment to clinical excellence and scholarly inquiry. We gather as a meeting of minds, yes, but also to celebrate the milestones that we have achieved in the art and science of medicine. As we reflect on a year of discovery over the next 2 days, we do so with a shared purpose: to embrace the innovations that will define our future and usher Kandy and Sri Lanka into a new era of health and wellness. To start off the evening's proceedings, and very fittingly so for the day, please rise for the pride of our nation, the national anthem.
Sri Lanka Mata, Upper Sri Lanka, Namo, 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 Namo Mata. Sundara Siri Barini, Surandi Ati Sobhamana Lanka. Dhanya Dhanaya Nekamal Balaturu Piri Jaya Bhumiya Ranya. Apahata Sapa Siri Seta Sadhana, Jivanaye Mata. Piliganu Mena Apabhakti Puja, Namo Namo Mata. Upper Sri Lanka, Namo Namo, Namo Namo Mata. Obave Apavidya, Obamaya Apasatya, Obave Apashanti, Apahada Tulabhanti, Oba Apa Aloke, Apage Anuprani, Oba Apa Jivanave, Apa Muktiya Obave, Nava Jivana Demini, Nitina Apa Kubudu Karan Mata. Gnana Vidya Vadavani Naragena Yanu Mena Jaya Bhumikara. Ekramavaka Gedaru Kalabalina,
Thank you. Ladies and gentlemen, as a mark of respect for time-honored culture and practice, please remain standing for the tradition of lighting of the oil lamp. We would like to cordially invite the following dignitaries to take part in this observance. Chief guest, Professor K.B. Galkatia, President of the Kandy Society of Medicine, Professor Arinda Dharmapala, Orator of the KSM Oration 2026, Dr. Subodha Vaidyanatha, Dean of the Faculty of Medicine, University of Peradeniya, Professor Saman Nanayakara, Dean of the Faculty of Dental Sciences, University of Peradeniya, Professor Shama Bannahaka, Deputy Director of Health Services, MS1, and Director of the Teaching Hospital Peradeniya, Dr. H.M. Arjuna Tilakaratna, Provincial Director of Health Services, Central Province, Dr. Sampath Ranavira, Regional Director of Health Services, Kandy, Dr. Chandana Vijay Singha,
Director of the National Hospital Kandy, Dr. Iresha Fernando, Director of the Sirimao Bandar Nayaka Specialized Children's Hospital, Dr. A.M.S. Veerabandara, Professor Indraji Amarasinghe, representing the past presidents of the Kandy Society of Medicine, President-elect of the Kandy Society of Medicine, Dr. Ayodhya Senanayaka, Treasurer of the Kandy Society of Medicine, Professor Chaminda Kandoda, Joint Secretary of the Kandy Society of Medicine, Dr. Asela Ratnayaka, and Joint Secretary of the Kandy Society of Medicine, Dr. Kaushika Gunasekara. Thank you, ladies and gentlemen. Please be seated. We now have the distinct pleasure of inviting the following dignitaries to take their seats at the head table. The chief guest, Professor K.B. Galkatia, the orator of the KSM Oration 2026, Dr. Subodha Vaidyanatha, the president of the Kandy Society of Medicine, Professor Arinda Dharmapala, Joint Secretaries of the Kandy Society of Medicine, Dr. Kaushika Gunasekara and Dr. Asela J.B. Ratnayaka, and the Treasurer of the Kandy Society of Medicine, Professor Chaminda Kandoda.
Thank you, Madam and Sirs. We would now like to extend a cordial invitation to Dr. Kaushika Gunasekara, Joint Secretary of the Kandy Society of Medicine, to deliver the welcome address.
Good evening, distinguished guests, ladies and gentlemen. As a Joint Secretary of Kandy Society of Medicine, it is my honor and privilege to warmly welcome you to the inauguration ceremony and the KSM oration of the 48th Annual Academic Sessions of Kandy Society of Medicine. The Kandy Society of Medicine is proud to host its 48th Annual Academic Sessions today. On this occasion, it's our great privilege to welcome Professor K.B. Galkatia, Professor of Surgery, Faculty of Medicine, Nursing and Health Sciences, Mildura Campus, Monash University, Australia, as the chief guest of this event. Professor Galkatia needs no special introduction to this distinguished gathering. Before his migration to Australia, he was a renowned surgeon, academic, and a researcher in Sri Lanka, and one of the pioneers in introducing complex laparoscopic surgery to the country. Sir, we are deeply honored by your gracious presence. Ladies and gentlemen, the highlight of today's inauguration is the KSM oration. The Kandy Society of Medicine is delighted to welcome our orator, Dr. Subodha Vaidyanatha, the senior lecturer at the Department of Parasitology, Faculty of Medicine, University of Rajarata. We take this opportunity to congratulate Dr. Vaidyanatha on this well-deserved honor and wish her every success in delivering an insightful oration. The Council also welcomes the family members of the orator to this ceremony. It gives me great pleasure to welcome Professor Saman Nanayakkara, the Dean of Faculty of Medicine, University of Peradeniya, Professor Shama Banheka, Dean, the Faculty of Dental Sciences, University of Peradeniya, Dr. Arjuna Tilakaratna, Deputy Director of Health Services, MS1, and also the current Director of the Teaching Hospital, Peradeniya. Dr. Sampath Ranaveera, the Provincial Director of Health Services, Dr. Chandana Vijayasinghe, Regional Director of Health Services, Dr. Iresha Fernando, the Director of National Hospital, Kandy, Dr. A.M.S. Veera Bandara, Director of Sirimau Bandaranaike Specialized Children's Hospital, and the Deputy Directors of these hospitals. I also take this opportunity to warmly welcome all past presidents of the Kandy Society of Medicine, consultants, professors, senior lecturers, and all other distinguished guests, distinguished invitees present here today. Further, I extend a sincere welcome to all local and international resource persons who have kindly accepted our invitation and are gracing this academic event. The Kandy Society of Medicine, fondly known as KSM, has a proud legacy spanning nearly 5 decades. Founded by visionary clinicians committed to advancing continuing medical education beyond the capital, KSM has grown into one of the most active regional medical societies in Sri Lanka. Since its inception, the society has served as a vibrant academic forum promoting lifelong learning, research, and professional camaraderie among doctors in the Central Province and beyond. The 48th Annual Academic Sessions continue this tradition of academic excellence. In keeping with this year's theme, Achieving Global Excellence in Healthcare Through Scientific Advances, the scientific program has been carefully curated to address contemporary challenges in the field of medicine, with contribution from distinguished panel of speakers. We truly hope that these sessions will be productive, intellectually enriching, and professionally rewarding for all participants. Thank you, and I wish you all a successful and a memorable academic session.
Thank you, sir. It is now my honor to invite Professor Arinda Dharmapala, President of the Kandy Society of Medicine, to deliver the presidential address.
Good evening, everyone. Chief guest, Professor K.B. Galkatia, the orator, Dr. Mrs. Subodha Vaidyanatha, Dean, Faculty of Medicine, Professor Saman Nanayakkara, Dean, Faculty of Dental Science, Professor Sama Banheka, DDHS, MS1, and Director of Teaching Hospital, Peradeniya, Dr. Arjuna Tilakaratna, the Director, National Hospital, Kandy, Dr. Iresha Fernando, Director Sirima Bandanayaka Specialized Children's Hospital Dr. Veera Bandara, Deputy Directors of National Hospital Kandy, Teaching Hospital Peradeniya and Sirima Bandanayaka Hospital, Provincial Director of Health Services Dr. Sampath Ranavira, the Regional Director of Health Services Dr. Chandana Vijayasinghe, past presidents, the council, senior professors, consultants and distinguished guests. It gives me immense joy and pride to welcome you all to this august gathering on behalf of the Council of Kandy Society of Medicine, one of the oldest and most respected medical associations in Sri Lanka. Founded by pioneers and giants of the medical profession in Sri Lanka, KSM has a proud legacy of service to medical education, research, and professional excellence. I am deeply humbled to carry this torch and to serve as the president of KSM for the year 2025. This occasion marks the inauguration ceremony of the annual academic sessions and the prestigious KSM oration for the year 2026. Professor Galkatia, dear sir, thank you very much for graciously accepting our invitation and traveling all the way from Australia to be with us as our chief guest. You remain one of the most loved and admired surgeons in Sri Lanka. I am certain that you have delivered many orations and distinguished lectures in the past, and therefore this stage and his audience are no strangers to you. Although you are from University of Ruhuna, University of Peradeniya has long embraced you as one of its own, truly an adopted son. Sir, you may have already noticed that many of the images we have used feature the artwork of landmarks of the University of Peradeniya. If you look closely at the invitation card, you will see the image of Gajasinghe. This is called Gajasinghe, a mural that adorns the bridge that just before the Senate. You may not be familiar with this story. I thought it would be fitting to share a well-known Peradeniya legend. It was told to me by a friend of mine who's here, Ishika, especially for those in the audience who are not Peradeniya graduates. Right, so this is where it is. The legend goes on to say that this Gajasinghe makes a huge noise, a combination of trumpeting noise of an elephant and lion's roar, whenever a virgin walks across this bridge. Anyway, up to now it has been so silent, not a noise was ever heard and not even a hum. So that's a legend, sir. Once again, thank you, madam. Madam is not here today, so thank you, sir, for gracing this occasion. Dr. Vaidyanatha, Dr. Subodha Vaidyanatha, yet another distinguished alumnus of the University of Peradeniya, I warmly congratulate you on your scholarly work and thank you for choosing Kandy Society of Medicine as the platform to present your oration on findings of the long-term sequelae of snakebite. From today, you will join the elite group of orators who have delivered this prestigious KSM oration. I believe your husband, too, is among this distinguished group, continuing the remarkable academic legacy. I wish you every success in your oration. I'd like to thank each one of you attending this inauguration, the annual academic sessions of KSM for 2026, giving us encouragement and support. I'd like to thank my scientific committee, led by Professor Manoji Patirage and Professor Chenal Talgahagoda, and also all the resource persons from Sri Lanka, as well as from UK, Australia, Canada, for spending your private funds and being here to support us. Your valuable contributions will surely make an indelible impact of the lives of our young doctors. Same time, I'd like to thank all the young researchers for sending all your abstracts, nearly 240 this time, and the chairperson of the abstract committee, Dr. Krishna Pradeep, for selecting the best to be presented here today. I like to acknowledge the presence of Honorable Sujiva Senasinghe, Member of the Parliament, former Minister of Science and Technology, attending this event not in his official capacity, but as one of my childhood friends, and all my other childhood friends who are here, this inauguration, and the Ranjit family. The Kandy Society of Medicine was established in 1964 by a group of doctors working at Kandy Hospital with the intention of upgrading the knowledge and the professional development of medical practitioners. From its inception, the society has also emphasized the importance of including paraclinical and allied health staff, firmly believing that excellence in healthcare can only be achieved through effective teamwork. Another key objective of the society is to build strong bonds and camaraderie among its members, which is fostered through various professional and social activities. As a responsible medical society, the Kandy Society of Medicine is also committed to fulfilling its social obligations by supporting the community during times of adversity and by educating the public on health-related matters. These objectives constitute the 4 pillars on which the Kandy Society of Medicine functions. This year's theme is achieving global excellence in healthcare through scientific advances. Sri Lanka, despite being middle-income country, has achieved primary healthcare indicators that are comparable to those of many developed nations. Our infant mortality rate, maternal mortality rate, and life expectancy stands as strong testimony to the effectiveness of our healthcare delivery system. These achievements have been made possible through the sheer dedication and commitment of our doctors, nurses, paraclinical staff, and healthcare administrators. They are not the result of efforts of a single individual or one professional group, but rather the outcome of a collective and collaborative effort across the entire healthcare system. However, despite these successes, there remains much more to be achieved. Professionalism is one such area that required attention. And over the past few years, under the leadership of Dr. Manjula and previous presidents, significant progress has been made in strengthening this aspect. Building on this foundation, my council and I felt that for this year, our focus should shift towards research, innovation, and evidence-based clinical practice. These are key areas that we aim to strengthen and actively promote among our membership in order to further advance the quality of healthcare we deliver. This year, we concentrated on these aspects, and our academic program for the year was guided by our theme. There was huge contribution from my council and other sister colleges in realizing these goals. We got experts in various fields and also lectures from overseas and in upgrading our knowledge. We had year-long Wednesday lecture series, workshops, and symposia, which was popular among the medical students, the PG trainees, as well as all the doctors. I like to acknowledge the hard work and for the commitment of our resource persons in all sincerity and to the loyalty shown towards the KSM. I take this opportunity to thank all of them that made academic contributions during the past year. Asela, especially, thank you very much for pulling this through over the past year. The KSM every year recognizes an individual who has contributed immensely to the field of medicine, bringing in new knowledge through research, usually a lifetime of work, and award the KSM Research Prize Gold Medal and the Oration. This year, Professor Ralapanava was awarded the prestigious KSM Research Prize Oration for the year 2025 on his work on biomarkers in cardiovascular disease. This was followed with a small academic program. The event was graced by our world-renowned scientist and emeritus professor of medicine, Professor Sam Kururatna. The annual academic sessions are the highlight of the academic year, featuring the lectures, workshops, and interactive sessions that promote knowledge sharing by experts from diverse fields. The program includes 2 prestigious orations, one today and the Memorial Oration tomorrow by Dr. Chanika Alahakwan, another alumnus of the University of Peradeniya. I thank the scientific committee, especially my secretaries Asela Kaushika and Anura Rajapaksa, for their dedicated and meticulous planning which will ensure the smooth conduct of these sessions. These sessions also provide a platform for young researchers. This year, we received 240 abstracts and nearly 200 selected for oral and poster presentations. I thank the abstract committee chairman and also Dr. Anura Rajapaksa for managing online review process, which is new. The abstracts will be published as a supplementary issue of the Sri Lanka Journal of Medicine. We also conducted 6 pre-congress workshops for doctors and a free first aid program for the forest and wildlife officers in line with our public health objectives. A photographic exhibition featuring selected works from 198 submissions curated by Dr. Kavind Amarasinghe is displayed outside the hall. Please visit during your free time, and the winners will be announced during the dinner. That's on 6th. The community obligations. The KSM has strong obligations to the community reflected in one of the core objectives of our society. We conduct an annual medical camp, and this year it was held in Madol, Calais. I wish to acknowledge the dedicated service of Dr. Chandana Kakulawala and his team. A total of 940 patients were treated, supported by nearly 50 doctors and 100 paramedical staff. One of the highlights of our community activities was our response to Cyclone Ditwa. When neighboring communities were affected, we promptly initiated a donation campaign, receiving generous support from our council members, general membership, and well-wishers. I would like to make a special mention of Mr. Inoka Nanayakara, who contributed 1 million rupees the very next day after the appeal was circulated, and also Professor Sivanandan, a well-known philanthropist, who donated another $1 million. These early contributions gave us the confidence to expand and sustain the campaign. Actually, all my council members and their families supported financially in this endeavor. The funds raised were used to distribute essential items, including dry rations, drinking water, clothing, and essential medicines. We were among the first professional organizations to respond, conducting simultaneous relief activities across the central province through multiple council-led teams. This enabled us to reach the affected families without any delay and was able to contribute when the real need was there. Following the immediate relief phase, we conduct medical camps in the affected areas. We did 2 at Ankumbura and Pujapitiya. I must thank Sampath Jnanaratna for organizing that. In addition, we contributed dry rations and clothes to these affected families. Psychological support is very important in every aspect. A psychological first aid program was conducted to Alawatugoda affected families and also in Galaha. We provided both physical and psychological support to the communities and also maintained a psychological support health phone line with the assistance of the Department of Psychiatry, University of Peradeniya. As the final phase of the campaign, we supported a school in Matale district where the entire community had been affected. We provided school bags, stationery, and uniforms to more than 250 students. This initiative was partly supported by Melva Group, which generously donated stationery items. I thanked Krishna, Ruanti, and Ashani for coordinating it so well, selecting each bag separately for each girl and boy and ages of 15 to 16 and like that. So thank you very much. Social activities. The KSM strongly believes in the bonding and camaraderie of its members, which is one of the key objectives of our society. In keeping with this spirit, we organized several social activities during the year. We commenced our social calendar with the Aurudhu Utsave, a truly fun-filled event that set the tone for the year. This was followed by one of the most eagerly awaited events, the law, medical, cricket, netball matches, concluding with fellowship dinner. Now, our ladies netball team was unfortunate this time, despite enthusiastic cheering. But the problem was most of this cheering seems to favor the lawyers team. Anyway, our gentlemen, of course, however, didn't receive that much of support. However, quietly won the cricket match, providing that doctors can perform well even without much applause. The evening ended up with a dinner dance where everyone danced the night away, and some more gracefully than others. The Bhakti Gi program and Thai Pongal celebrations were held at the cancer home and the elders' home in Gatambe. We organized our carol service at the elders' home in Mahayav and shared dinner with the residents. The council spent several hours engaging in warm and meaningful conversations. These events were supported not with glamour but with genuine love, care, and compassion. Another major highlight was the family concert, which attracted an unexpectedly high level of enthusiasm. A special attraction was the well-choreographed dance performance by a group of old male consultants, thankfully completed without any cardiac events or any emergency referrals. The kids' drama with beautiful costumes and impressive backdrops were so amazing, and the talent was unbelievable. This event truly stood out with its glamour and glitter. I sincerely thank the Council for their unwavering support, especially our social secretaries, Dr. Ranmini and Dr. Kakulavala, and Drs. Indika, Amila, and Senani, for keeping the social activities running so smoothly. Ladies and gentlemen, these are just a few glimpses of the work carried out by the KSM in fulfilling the objectives of our society and aligning with the theme of the year. I was fortunate to have worked with a highly dedicated council and with two energetic secretaries who are, like the medical people will know, P53 gene, which doesn't allow anything to go ahead without their scrutiny. My role was made remarkably easy. I will not mention all names, as that would take an hour. However, I must specially thank our treasurer, Professor Shavinda Kandauda, and Dr. Saman Walisinghe, along with the finance committee, Charles, Chaturanga, Duminda, Manoji, and Manjula, for their meticulous handling of the finances, and our little Pasindu office manager, who is our lifeline. I extend my special thanks to Gamma Interpharma and its chairman, my good friend Mr. Karana Hevamallika, for being the premier sponsor this time for the annual academic sessions and for the exciting prizes at the dinner. I also thank our gold sponsors, Asri Hospital, Sugar 7 Hospital, and Farm Evo, and all other sponsors for bearing the major financial burden of these sessions. I also like to thank the hotel for their excellent support and cooperation. Finally, I wish you all a fruitful scientific session and a joyful evening today. Thank you.
Thank you, sir. I would like to once again invite the President of the Kandy Society of Medicine, Professor Arinda Dharmapala, to introduce the chief guest for this evening, Professor K.B. Galkatia.
Good evening again. You're going to hear me again. Let me get this right. Good evening, everyone. So, dear sir, I was given this pleasant task of introducing you as our chief guest. I think I should thank Manjula Herath, who is here, for his generosity and allowing me to invite you this year as the chief guest. Right? Otherwise, you would have been the chief guest last year. Thank you, Manjula, for allowing me to get it. Professor Galkatia needs no introduction. If one were to attempt to introduce you, the list would be long. And it will go like this. Sir, an exceptionally skillful surgeon, so humble, generous human being, and above all, a truly kind person. These are just some of the traits you have gathered on your remarkable journey or you are born with. You have been a mentor to many of us, shaping not only our surgical careers, but as also our values as clinicians and as human beings. Your kindness touched countless patients as well as your colleagues. That itself is your introduction, sir. And that is who you are. But as a formality, I will read some of his excerpts from his CV. Professor K.B. Galkatia, MBBS, MS, Fellow of the Royal College of Surgeons, Glasgow, Fellow of the Royal College of Australian Surgeons, Fellow of the Association of Minimally Invasive Surgeons of India. And he is the clinical director and the specialist general surgeon in Midura Base Hospital, Victoria, Associate Professor of Faculty of Medicine, Nursing, Health Sciences, University of Monash. He was a former professor in surgery, Faculty of Medicine, University of Peradeniya, and former consultant surgeon, Ministry of Health, Sri Lanka. Professor K.B. Galkatia attended the wrong school in Kandy. Actually, it was his father who made that wrong decision. His primary education was at St. Anthony's College, and getting through his advanced level, he entered the Faculty of Medicine. University of Ruhuna, where he obtained his MBBS. He later enters into the postgraduate training in general surgery and obtained his master's in surgery. He did his registrar period with Professor Sharif Dean, Professor Jerry Jayasekara, Professor Dayasiri Jayasekara, three of the best at that time. This gave his liking towards the vascular surgery and GI surgery. He did his overseas training at Westmead Hospital, New South Wales, Australia, as a specialist registrar, another stint at Whittington General Hospital in UK, where he specialized in vascular surgery. Upon returning back to Sri Lanka, he has worked tirelessly in Anuradhapura and Polonnaruwa hospitals during the era of the Civil War, where there was inundated amount of war casualties. Thereafter, he worked as a surgeon in Mathara and Karapitiya, where he initiated laparoscopic work and became a pioneer in laparoscopic surgery in Sri Lanka. Then he joined University of Peradeniya, and he did amazing work here academically as well as clinically. He did a lot of clinical related academic work where he was able to get grants and use them to purchase consumables to improve the quality of minimally invasive surgery. This was his passion. He became a professor in surgery in no time. As a surgeon, I would like to mention here the amount of work he did was incredible, especially in minimally invasive surgery. With very limited resources, he changed the landscape of Sri Lankan surgery. He was a pioneer in laparoscopic surgery and introduced laparoscopy beyond cholecystectomy to esophagectomies, colorectal surgery, pancreatic surgery, and liver surgery, which are most complex surgeries one can perform. You made it look so simple with your scope. This paved the path to younger generation of surgeons to take up laparoscopy. You have been a mentor for many. Some of them are here in the audience today. Professor Galkatia has published well over 75 peer-reviewed articles and so many abstract presentations. He has been many advisory boards and took up the challenge and had a wonderful congress in 2017, being the Congress Chair of the Scientific Sessions of College of Surgeons of Sri Lanka under the presidency of Professor Lamavansa. I am sure it would have been a very pleasant experience for you. He has served in Board of Study in surgery for many years and being an examiner in Part 1 and Part 2 postgraduate exams. The work and the dedication you have shown in teaching, mentoring, and being a role model for many of us cannot really put down in words. You are a giant in the field of surgery, yet a gentle one. On a personal note, you have helped me to blossom as a young surgeon even though I was not a trainee of yours. I met you in my early years as my senior colleague. You groomed me, gave me courage to start work on HPB surgery. When you were there in the background, it gave us confidence. It is not only me, it is how we all feel at the department. I use this picture as the last slide at the end of my oration done some years ago, showing this beautiful creeper in full bloom, and an iconic picture of the University of Peradeniya. Everybody talks about the flowers and the creeper, yet nobody sees the tree which is holding it so high up in the sky for it to bloom in its full splendor. We all feel it is you, the tree that is holding all of us for us to bloom. Here I have put up only few surgeons, but there are many more. We all feel it is, this is how we feel, and what made us to invite you here as chief guest. So honor you for your services rendered to Sri Lanka and its people. Now I would like to invite Professor K.B. Galkatia to the podium to speak a few words. Thank you.
Good evening, everyone. Thank you for the kind invitation. And Professor Arinda Dharampala, Arinda, one of my best colleagues, an outstanding surgeon who is outstands than me in surgery, for the extra kind introduction. But there's something unknown to you I'll disclose. Even though you introduced me as a Rohuna graduate, which is true. The first 2 years I was at Peradeniya, and then for 2 years, day and night, I was waiting at the bridge you said. And the silence made me disappointed, and I left to Gaul. And in Gaul, I progressed well, simply because there was no such bridge there. And Arinda also let me thank I made a request that I'll maintain my free style of talking, sometimes talking out of the box, and he said, totally all right. Anyway. It's an quite impressive theme for the year and for the conference. And how to go there and what's our responsibility. And all of us, in this progressive scientific advances, we fit into a certain block of time after intensive training and then finally certified as competent for a safe clinical practice. And then comes what is called deliberate practice. There's a lot of discussion on this, but very simply it's the repeated, intelligent practice which will take us from mere competence towards being an excellent clinician. And to remain there, we have to continue practicing, which is called the recency of practice, and also we have to continue to learn. And at best, if possible, contribute. So all this will take us towards excellence. And to have a quick look at few selected milestones dating back to about 12,000 years before Christ. Early records of Ayurveda, followed by scientific progress of the Western medicine. And, sorry, that went off, but various professional bodies forming, which also recalls that the ancestors of former surgeons were barbers. Sorry, it's going back. And vaccines, anesthesia, then gynecology branching of surgery, soon followed by blood transfusions. Those two are not connected anyway, gynecology and blood transfusions. And infections, antisepsis, antibiotics, X-ray. So over so many millennia, there had been a progressive increase of these batteries going off of the surgical field. Sorry, this computer shows the batteries down. Anyway, quite interesting, during the last 25 to 30 years, there had been a huge jump in the medicine, big advance due to technology introducing so many machines and introducing maybe like upgrading existing machines, to show a few, and also machines taking over body functions like cardiopulmonary bypass, dialysis, pacemakers, and also advances in radiology, taking us into a new dimension of accurate diagnosis. But to look back at 30 years, when I started as a surgeon at Apollo Anuradhapura, we only had plain X-ray and contrast X-ray, and no on-site radiologists. But still people made diagnosis with the art of history taking and careful examination. And technology has come into treatment, especially in surgery, and this has taken a huge chunk of the surgeons, but for better management of patients, endovascular, cardiac and peripheral, interventional radiology, and physicians performing procedures with endoscope. And the next wave, I'm not sure whether this will upskill or downskill us, but it's already tested for radiology reporting and dermatological diagnosis. And the surgical robo, currently slave, I'm sure with AI, the robo will become the master. But I wonder, and looks as if the robo is also wondering, that the master robo will be continued to be bossed by the anesthetist. with all this technology coming in, we have to grasp it. But just have a look back and don't forget of the human factor. The technical skills and similar importance to non-technical skills or the soft skills, which should be taught during training and especially at practice if we are going to march towards excellence to maintain a good doctor-patient relationship and an ethical practice. And something often we neglect for ourselves is this. Being a job 24/7, working through nights, weekends, public holidays, and the nature of work, medical jobs are stressful. Acute stresses. Oh, sorry, I forgot something. Working after hours in private practice may also add to, but looking at the expressions, I don't know whether it's a stress reliever. People look very happy. I'm not sure, so I'm not going to comment on that. So anyway, acute stresses and especially surgeons are supposed to have a chronic stress level, which may well account for their outstanding behaviors. And well, I'm not going to suggest solutions because they're out of my field, but as a victim, I can say one of the key weapons or key things against stress is have a good initial training, continue to work, continue to learn, continue to work. It's a secret. Having said that, as I mentioned once before, some surgeons have taken a shortcut. Marry a psychiatrist. Arinda, I wonder whether you regret inviting me. Anyway, but I think have a very strong psychology. And for any trainees who are in the audience who are planning for overseas training, please keep this in mind. Have a very strong positive minds, positive psychology. You're going to settle in a same medicine but different setup. Keep your mind strong and then it will let your skills shine up. Fatigue, maybe soon after work or sadly even after work, even during work. West has addressed this extensively, but I think it has resulted negative impact on training. So we have to be cautious, but still be mindful of your own fatigue and as well as the fatigue of your trainees. And if you do this, as a trainer, you'll ever live in their hearts. And take some holidays. Trust me, the very busy people, busiest of its kind, take holidays. But remain connected. Not only the laptop, mobile, both. That's all. So, putting everything together to reach the global excellence, I think the key things are we have to provide initial good training. So as trainers, we have that responsibility. Just an observation, I think we err too much on loading specialist knowledge. I'm talking undergraduate. Postgraduate, excellent, because there's no lectures, self-learning, apprenticeship-based training. Undergraduate, we tend to load a lot of specialist knowledge, and then we have a stream called paraclinical because it runs for about 2/3 of clinical time. But this paraclinical knowledge is the foundation for clinical. So we start our clinical without this foundation knowledge, which will actually hamper proper clinical learning in the first few years. So a lot of universities in the world have moved out to teach the very basic stuff and finish all this foundation and then start the clinicals, and the clinicals are more useful or more meaningful. And also, of course, these things, some things cannot be changed, but our clinical training is it's centralized to few teaching hospitals, which leads into so many students per consultant. But a lot of countries, they disperse to a lot of hospitals because they have finished the foundation, and for clinical training, it's very small groups. But anyway, but still, what I see is at the end of internship, our graduates outstand a lot much ahead of the Western graduates simply by the deliberate practice of what they have learned as a first contact doctor for 1 year through a lot of hard work, which is very important. But during this period, we have to look after them. We have to teach, we have to train, support, look after their stress and fatigue, especially at the initial period. So that's a key. Good training, deliberate practice, and then continue medical education research. So looking at the level of execution through the infrastructure and manpower, it's a Ministry of Health which is a service provider. But to train the medical workforce, the ministry hires the university system. And to my best of knowledge, out of all degrees, it's a medical degree, medical and allied medical, whatever, uses job-based or apprentice training to the maximum. So therefore, the universities in reverse uses the Ministry of Health to get the job-based training. So it's a syncytium, and both units should function in a harmony. And any recent advances, the Ministry of Health has to fund and take them in, while the university should have the responsibility to train people into that. Like when minimal access came, none of us are trained. So the training is important as new things come. Otherwise, it's very difficult to implement them. And then, looking at continuing medical education, so it has to be meaningful, both has to work together. There are many professional medical associations looking after continuous medical education excellently well. And Kandy Society of Medicine has done this over so many years. And let me congratulate the president and his team for taking the flag very strongly over the year, organizing so much of CME, as Arinda pointed out, and then also in the next 2 days, a platform to present research and also to publish through the regular journal. And not forgetting the stress and fatigue, so much of social events. It's a responsibility of the membership to use the maximum of this. In our country, because of workload, we have a bit of a back foot for CME. But always by organizing, it's possible to participate, and it's very important to provide protected time for trainees to participate, because it is our joint effort or the commitment which will drive us towards the required goal of global excellence at infinity. Thank you.
Thank you, sir, for those thought-provoking words. I would like to invite Professor Arinda Dharmapala, the President of the Kandy Society of Medicine, to award the token of appreciation to Professor K.B. Galkatia.
Ladies and gentlemen, the time has now come for the highlight of today's ceremony, the prestigious KSM Oration 2026. This year's oration is titled Life After Surviving a Snakebite in Rural Sri Lanka, Lessons Learned and the Way Forward. To introduce our esteemed orator and to award the medal for the KSM Oration 2026, I once again would like to cordially invite Professor Arinda Dharmapala, the President of the Kandy Society of Medicine.
It is indeed a pleasure and honor to introduce our orator tonight. She's alumnus of our university, and I may have taken classes for you all when I was a SR at Peradeniya. So Dr. Subodha Vaidyanatha is a past pupil of Swarna Jayanti Mahavidyalaya, Kegol, and St. Joseph's Girls College, Kegol. She entered the Faculty of Medicine at the University of Peradeniya in 2003 and earned her Bachelor of Medicine and Bachelor of Surgery degree with second-class honors in 2008. Dr. Vaidyanatha completed her internship at Teaching Hospital Anuradhapura and then worked as an additional medical officer of health in Mihintale. In 2017, she began her academic career as a probationary lecturer in the Department of Parasitology, Faculty of Medicine and Allied Sciences, Rajarata University of Sri Lanka. In 2025, Dr. Vaidyanatha completed her PhD from the Rajarata University of Sri Lanka under the title Investigations of a Long-Term Effects of Snake Envenomation in a Cohort of Snake Envenom Patients in Rural Sri Lanka. She has won multiple awards for her research, including the Best Oral Presentation Awards at the Annual Congress of the Asia Pacific Association of Medical Toxicology in 2019, the Presidential Award for Scientific Publications in 2020, and several Vice Chancellor Awards and Dean's Awards. She has published 8 full research articles in major toxicology journals, including 3 in clinical toxicology, 2 articles in PLOS, NTD, 2 in Toxicon, and 1 in Toxin. She is a reviewer for several international journals, including PLOS, Neglected Tropical Diseases, British Journal of Clinical Pharmacology, and BMC Public Health. Dr. Vaidyanatha is married to Professor Anjana Silva and blessed with a son, Kemitha, who is 12 years old now. She enjoys baking during her leisure time. That is quite interesting. I like to call her to receive the medal and to deliver her oration. All the best to you, Subodha.
Professor Arinda Dharmapala, the President of the Kandy Society of Medicine, thank you very much for your kind introduction. Chief guest, Professor K.B. Galkatia, guest of honor, President and the Council of KSM, distinguished guests, and my colleagues. A very good evening to all of you. I thank the Kandy Society of Medicine for selecting me to deliver this year's prestigious KSM oration. It is absolutely an honor for me. As a proud Peradeniya graduate, I'm so excited to deliver this year's oration in front of this distinguished audience with many of my beloved teachers. For the next 45 minutes or so, I will share my experience with the long-term effects of snake venoming in rural Sri Lanka and future directions for optimal care of snake bite survivors. I declare that I have no conflicts of interest, and I will be showing some of the photographs of the patients which were taken with their consent to be used for teaching and research purposes. Snakebite is a significant public health concern in South Asia, Southeast Asia, Sub-Saharan Africa, and Latin America. These regions account for more than 90% of the global snakebite burden, which is approximately 0.5 to 1.8 million cases per year. Snakebite is a disease of poverty, an occupational health hazard associated with farming, especially in countries where health systems are weak and medical resources are sparse. In many affected regions, inadequate reporting of snakebite has led to a poor understanding of the true disease burden. As a result, the World Health Organization added snakebite envenoming to its list of neglected tropical disease in 2013. In 2019, it initiated a global strategy aiming to reduce snakebite-related deaths and disability by half by 2030, emphasizing the importance of global health priority. Sri Lanka's snakebite incident rate is one of the highest in the world. According to a community-based survey, the estimated annual incident rate is 398 snake bites and 151 envenomings per 100,000 population. The North Central Province is the most affected region and has 3 times higher envenoming rates compared to the national figures. The majority of the people in North Central Province are engaged in paddy farming and dry land farming, either full-time or part-time. And snakebite has been a part of their lives for generations. This is because of the abundance of the venomous snakes in the dry zone and the direct encounters between human and snake at the farmlands due to unique farming practices, irrigation systems, and the climatic factors like monsoon rains. Due to the diversity of the ecological and climatic factors, Sri Lanka has a very rich herpetofauna. Currently, Sri Lanka's snake fauna includes 109 species, of which 60 are endemic to the country. Among them, 5 are snakes of the highest medical importance. They are Russell's vipers, Indian crate, Merrim's hump-nosed viper, common cobra, and saw-scale viper. All these snakes are inhabiting dry zone. Snakebite can cause both local and systemic envenoming during the acute stage. In Sri Lanka, hump-nosed viper and cobra bites commonly cause local effect, while systemic envenoming is primarily associated with Russell's viper, Indian crate, cobra, and saw-scale viper bites, and also occurred in some patients with hump-nosed viper bites. Acute effects of snake envenoming are relatively well described in both local and international literature because of the better documentation and reporting during the hospital stay. As a result, knowledge of the acute envenoming is relatively strong. In contrast, long-term effects are poorly described. This is mainly because once the patients are discharged from the hospital, they are lost to follow-up, leading to underreporting of long-term effects. President, Council, and distinguished guests, my path to research was never planned. After completing my MBBS at Peradeniya Medical Faculty, I completed my internship at Teaching Hospital Anuradhapura, then served as AMOH Mihintale for 4 years. As an AMOH, while running clinicals in rural areas, I directly engaged with the people, which provided me a complete new perspective on the socio-economic determinants of health in rural Rajarata community. After joining the Department of Parasitology at Rajarata Medical Faculty, as a probationary lecturer, I wanted to pursue a postgraduate degree. However, I had no prior research experience. So I discussed this with my husband, who is a toxinologist himself, the topic I should select for my postgraduate research. He suggested me to study the long-term effects of snake envenoming as the topic is underexplored. This is how I began my journey as an amateur researcher under the supervision of Professor Jeffrey Isbister, a leading toxicologist at the University of the Newcastle, Australia, and Professor Cecil Siribadan from Rajarata Medical Faculty. So, as a starting point, while looking for the available literature, we noted the paucity of a review article on long-term effects. So, I started working on a scoping review. We used various combinations of research terms and research in Medline. We used a various combination of search terms and searched in Medline and Embase since 1950s. Clinical condition lasting or appearing more than 6 weeks following snake bite were considered long-term or delayed effects. After removing duplicates, we screened 257 records, from which 88 articles were eligible for the review. From that, only 5 articles were included in the review. The scoping review highlighted a range of long-term effects of snake envenoming, including local, renal, psychological, neurological, endocrine, and non-specific symptoms. One of the most significant long-term outcomes is the persistent local effects. The tissue damage caused by snake venom during the acute stage can lead to long-lasting local complications. These are frequently observed following bites from true vipers, pit vipers, and some elapids. Patient may end up in amputations, extensive scarring, and deformities from chronic wounds, persistent pain, and lymphedema, which could greatly impair their quality of life. Patients who develop acute kidney injury following the snake bite, especially viper bites, can get chronic kidney disease later in their lives. Persistently elevated serum creatinine levels and duration of the renal replacement therapy during the acute stage were recorded as positive predictors for the development of long-term renal impairments. Moreover, snake bite is reported to cause long-term neurological problems, mainly due to intracranial hemorrhages caused by venom-induced coagulopathies, or ischemia secondary to cardiorespiratory paralysis during acute stage. Hemorrhagic infarctions and vascular toxins in the Boyar species are reportedly damage the pituitary gland, causing hypopituitarism later in life. Although venom itself does not directly affect the psychological well-being of a person, the traumatic experience of getting bitten by a snake and its effects and the socioeconomic consequences faced afterwards reportedly triggered the development of depression, post-traumatic stress disorder, and somatization. In some studies, patients have reported having non-specific health concerns following snake bite, which include body aches, pains, weaknesses, tiredness, visual impairment, and certain dental issues. However, upon critical evaluation of these studies, we found that the most published literature has described the long-term effects retrospectively. They have correlated the patient's current health issue with a past snake bite incident that were poorly recorded. Most lack accurate and reliable data on the acute presentations and their management. In most cases, there were no offending snake authentication. Therefore, it is clear that the prospective study is the way forward in studying long-term effects of snake bites. We published this scoping review in the journal Toxins, which is the first global review on long-term effects of snake bite. In my PhD, I decided to prospectively explore the prevalence and severity of the long-term effects of snake bites. Moreover, we aim to assess the risk factors for the development of these long-term effects and the health-seeking behaviors of the snake bite survivors in relation to these concerns. As I mentioned earlier, my first post-intern appointment was the AMOH in Mihintale. Most families there depend on farming, either full-time or part-time. Every single day, I witnessed the immense physiological and emotional labor they pour into their paddy fields, chenna cultivations, and home gardening, ensuring that food reaches our table. Their lives are defined by constant struggle, battling droughts, sacrificing sleep to spend long, fearful nights in tree houses, and protecting crops from wild animals. Most notably, these farmers are also among the most vulnerable for snake bite, as Anuradhapura considered the snake bite capital of the world, with the highest number of envenoming reported annually. Living and working among these communities made me realize that there is no place more relevant or more deserving than Anuradhapura to study the long-term effects of snake envenoming, because there the burden is real. The consequences are lived daily, and the need for understanding and action is profound. We plan to conduct a prospective clinical study to describe the health problems of snakebite survivors within the first 3 months and thereafter, with follow-ups at 1 year and 4 years. This approach aims to assess perceived health issues and renal functions over the time. Additionally, we intended to examine long-term health effects just after discharge and how patients seek health care for these ongoing issues during post-acute stage. Furthermore, I wanted to investigate the prevalence of serum sickness among the patients treated with Indian polyvalent antivenom, which is primarily used for the envenomation in Sri Lanka. For this, we decided to study patients enrolled in Anuradhapura snakebite cohort. The Anuradhapura snakebite cohort was established in 2013 by Professor Anjana Silva, Professor Sisira Siribadana, and Professor Senaka Pilipitiya at the Teaching Hospital Anuradhapura. All the confirmed snakebite patients admitted to the Teaching Hospital Anuradhapura are enrolled for this cohort, and the data are prospectively collected by medical or nursing graduates around the clock. The cohort is still going on successfully, and to date, we have recruited over 8,000 patients, making it the largest snakebite cohort in the world. In the Anuradhapura snakebite cohort, data are recorded at hospital admission, 6, 12, and 24 hours following the snakebite and daily thereafter until discharge. We collect comprehensive demographic data, past medical history, detailed information regarding the snakebite incident, pre-hospital interventions including first aid measures, acute clinical manifestations of envenoming, complications that develop later on, and laboratory data, acute management strategies, and the patient's discharge plan. Blood samples are collected for venom detection ELISA. So, we decided to review two groups of patients from Anuradhapura snakebite cohort, 1 year after the bite and 4 years after the bite, to describe the persistent musculoskeletal problems and the other health issues perceived by them in relation to the snakebite and to assess their renal functions as well. For this, we established a review clinic in the Teaching Hospital Anuradhapura, kindly facilitated by Professor Sisira Siribadana, my PhD supervisor. I conducted this clinic 4 days per week in the mornings for more than 1 year. The Anuradhapura snakebite cohort has contact details of the enrolled patients, so we contacted them over the phone, and if the telephone numbers are unavailable or not contactable, we send them invitation letters inviting them to attend the clinic. Failing that, the field research assistant, Mr. Arunasiri Muhandiram, went to the houses of the patients to invite them to attend the clinic visits. He visited every corner of the remote Anuradhapura to recruit patients for the clinic, a task made difficult by poor road infrastructure and challenging environmental conditions. Convincing a person in the community to commit an entire day to attend a clinic that they never really wanted to attend was challenging. We provided incentive for all the patients at the end to compensate their travel cost and daily wages. Finally, I reviewed 199 patients after 4 years and 168 after 1 year since the snake bite in the review clinic. A total of 367 patients, and 78 of them were contacted by paying home visits. I took a complete history from each of these patients to record the health issues perceived by them in relation to snake bite and screened them for psychological problems when indicated using PTSD scale, GAD-7 and PHQ-9. Complete physical examinations was done to assess the persistent musculoskeletal problems. I should thank Professor Siribadana for being there for me throughout this entire process, because whenever there is a patient, we needed further medical care. Even for things unrelated to snake bite, we provided them with the necessary health supports. Blood and urine samples were taken from all the patients for serum creatinine levels and to assess the albumin-creatinine ratios. From all the reviewed patients, the majority were males and typically middle-aged farmers. 3/4 of the patients were bitten by the Russell's vipers or hump-nosed vipers. Of the patients who were reviewed 4 years after the snake bite, 54%, means half, complained of health issues that they related to the snake bite, while 33%, 1/3 of the patients who were reviewed after 1 year of the snake bite, also had such complaints. However, among all the patients I reviewed, only 16 had persistent musculoskeletal effects, which include digital amputations, contracture formations, and scar formation. None of these issues were debilitating, but patients were concerned about the deformities. More interestingly, there was another group of patients who complain of health issues which cannot be explained by the pathophysiology of the envenoming mechanism. From here on, I use the term medically unexplained symptoms to describe them. We could categorize them into two broad groups. The one is problem involving the oral cavity, in which patients complain of recession of gums, teeth becoming weak, brittle, loosening and avulsion. The other group is non-specific symptoms, in which patients complain of getting tired, fatigue easily, difficulty in working in bright daylight and body aches and pains. We noted that these medically unexplained symptoms tend to increase with time, with 25% of the patients after 1 year compared to the 52% after 4 years. So we did a univariate logistic regression and found the presence of the medical unexplained symptoms was associated with the time from the snake bite, farming, viper bite, local envenoming, systemic envenoming, neurotoxicity, coagulopathy, administration of antivenom, anaphylaxis to antivenom, and the number of days hospitalized at the time of the bite. Multivariate logistic regression too did not satisfactorily explain the variation in symptom reporting. We could determine whether these symptoms are true effects of severe envenoming or originating from the knowledge and experience that they had due to severe envenoming. Notably, the proportion of the patients reporting symptoms were twice after 4 years compared to 1 year. This may suggest that the patients tend to link various health issues that they perceive to the snake bite over time. In both groups, approximately half of the patients were constantly alert while working outdoors following the snake bite, but wearing protective gear while farming was minimal. There were 144 farmers in group 1. Among them, 6 have restricted farming and only 1 has quit farming after 4 years following the snake bite. But in the group 2, none have restricted or quit farming activities due to fear of snake bite. Regarding the psychological impact of the snake bite, fewer problems were observed than expected following screening. Only 1 patient from both groups had notable problems. This patient was a 41-year-old male, an ex-army soldier from group 1, who was bitten by an Indian crate while sleeping. And he developed severe neuromuscular paralysis requiring antivenom therapy and ventilatory support. For the past 4 years, he reported re-experiencing the event, including sensation of snake moving under the bed cover while sleeping, and on 3 times during sleep, he also experienced choking and breathing difficulties similar to the symptoms he had immediately before the intubation. However, these re-experiencing episodes did not interfere with his daily activities. The patient was assessed using the PTSD checklist and scored below the provisional diagnosis of PTSD. He was subsequently referred to a consultant psychiatrist, and further evaluation confirmed that he did not meet the clinical diagnostic criteria for PTSD. President, Council, and the distinguished guests, at follow-up, 1/3 of the patients at 1 year and half of the patients at 4 years reported health issues that they attributed to the snake bite. However, unlike in many other regions in the world, musculoskeletal problems were less severe among the patients we reviewed. Many reported symptoms are non-specific or related to oral health, but could not be readily explained by the non-pathophysiology of snake envenoming. These findings suggest the need for more in-depth investigation of the socio-cultural factors that may contribute to the symptom reporting after snake bite. So, we believe well-designed qualitative studies are required to provide robust exploration of the socio-cultural elements behind these symptoms. We published these findings in PLOS NTD. Chronic kidney disease of unknown etiology, or chronic interstitial nephritis in agricultural communities, or CINAC, is a condition where there is no recognizable etiology that causes renal disease, such as diabetes mellitus, chronic or severe hypertension, snake bite, glomerulonephritis, or any other urological diseases. Anuradhapura is an endemic region for CINAC, where the prevalence of snake bite is also highest. Previous studies have identified past snake bite as a significant risk factor for SNAC. The basis of the association between the development of CKD following snake bite in a SNAC endemic region remains poorly understood. And we don't know whether it is due to the shared risk factors or due to causal association. Therefore, we assess the long-term renal status of the patients with snake bite in our cohort. For this study, we used the renal functions data from 2 groups of patients collected 4 years and 1 year after snake bite. We investigated serum creatinine levels and urinary albumin to creatinine ratios. At the review visit, an eGFR was calculated using CKD EPI 2021 equation. There, we noted there is no difference in eGFR levels between patients bitten by vipers and those bitten by non-viperine snakes. Similarly, there was no difference in eGFR levels between envenom patients and non-envenom patients in both groups. According to the Anuradhapura snake bite data, snake bite cohort data, there were 28 patients from both groups who had abnormal eGFR on discharge from the hospital. Of them, 24 had normal eGFR on review. All the patients who had AKI during acute envenoming had normal eGFR on review. The patients who had abnormal eGFR on review were found to have either pre-diagnosed CKD or comorbidities for CKD. On review, we found in both groups, approximately 25% of the patients had elevated albumin to creatinine ratios. Almost all of them had microalbuminuria except 4 who had macroalbuminuria. However, there was no difference in ACR in patients with viperine bites and non-viperine bites, or envenom patients versus non-envenom patients in both groups. Univariate logistic regression found that albuminuria was associated with comorbidities for CKD and age more than 60 in group 1, while in group 2 it was associated with comorbidities for CKD, presence of AKI in acute stage, and eGFR less than 60 on discharge from the hospital. Following multivariate logistic regression, the final model for group 1 included only comorbidities for CKD, which explain 23% of model variance, while the final model for group 2 included comorbidities for CKD, AKI at the acute stage, and the type of snake, explaining 54% of the model variance. According to KDIGO criteria, there were 9 reviewed patients with CKD grade 3 to 5, but all the patients were either pre-diagnosed with CKD or had comorbidities for CKD. Therefore, we didn't find an association of developing chronic kidney disease or SNAC in patients who were bitten by venomous snakes or who developed acute kidney injury. Presence of microalbuminuria likely due to underlying comorbidities such as hypertension, diabetes mellitus, and background renal injury due to SNAC in this farming community. We published these findings in the Clinical Toxicology Journal. Once I started reviewing the patients, I realized that some of their problems were continuous since the snake bite, and some of the patients had sought treatment on their own for these issues. Therefore, we investigated persistent and new health issues among snake bite survivors after hospital discharge. For that, we wanted to review patients 3 weeks and 3 months after the snake bite. In early 2021, the COVID-19 pandemic began to spread worldwide. We waited for months to see patients in our clinic, but prevailing circumstances were not conducive to continue operations. Therefore, we decided to review the patients by phone, given the time constraints for my PhD. We initiated telephone follow-up with the expectation of reaching most patients, given that the lockdown provided sufficient time for remote reviews. However, this proved challenging. A total of 710 patients were recruited. Of them, 521 could be contacted at 3 weeks and 384 at 3 months. Overall, nearly half of the eligible patients could not be included despite daily contact attempts for 1 week at each follow-up point. This was likely due to poor mobile network coverage in remote areas, the activation of phone subscription for financial reasons during pandemic, the national economic crisis, and rolling power outages that frequently disrupted telecommunication services. On the telephone review, I used a structured questionnaire to inquire about the persistent and new health issues perceived after discharge, and their durations and the treatment-seeking behaviors in response to those health issues. The effects of the health problems on their daily routines and occupation after discharge is also documented. Following the review, I found that 65% of the patients had persistent health issues at hospital discharge. These were primarily local effects of snake envenoming, including pain, swelling, unhealed wounds, and numbness at the bite site, predominantly associated with hump nose viper bites. At 3 weeks after the bite, 26% of the patient had persistent local effect with similar pattern, mainly due to hump nose viper envenoming. And one patient had to undergo an amputation of a digit after discharge. At 3 months, 14% of the patients reported persistent local effects. Moreover, 9% of the patients complain of medically unexplained symptoms like easy fatigability, tiredness, and aura-like symptoms, while 2% patients experienced fear and were reluctant to engage in routine activities even 3 months after the snake bite. Of the reviewed patients, 38 were given instructions at discharge to follow up at the teaching hospital Anuradhapura for reassessments, mainly renal functions. Of them, 82 had adhered to the instruction and visited the hospital, but 29 of the discharged patients reported self-motivated seeking of health care, mainly due to persistent local effects. We found that 77% of them have visited indigenous medical practitioners. Their main reasons were persistent local effects and to remove the residual snake venom from their bodies, as they believed the hospital treatment does not completely remove venom from their bodies. In this group of patients, median loss of working days after discharge was 2 days, and 99% of the patients returned to their daily routines by 3 months. President, Council, and the distinguished guests, in this study, we found that most snakebite survivors leave the hospital with unresolved health issues, mainly local effects at the bite site caused by vipers. And they have sought treatment for these issues mainly from indigenous medical practitioners. These findings highlighted to us that although we provide acute care at the hospital and save the lives of the snakebite victims, the patients continue to experience minor issues, for which their treatment-seeking journey continues. Due to limited resources, it is difficult to retain these patients in the hospital for minor unresolved issues, such as persisting swelling at the bite site. So, it is important to provide a clear discharge plan that addresses these issues and educate and reassure patients about the expected course of their symptoms. Additionally, the role of indigenous practitioners in the community, particularly in providing psychological reassurance to the snakebite victims through the removal of residual volume, as they believe, may also be beneficial as long as they do not harm. This may also be an example of a pragmatic use of medical pluralism in Sri Lanka. We published these findings in Toxicon. Additionally, in our studies, we found that hump-nosed vipers are the species most frequently associated with unresolved health issues. Hump-nosed vipers are responsible for most snake bite in wet zone of Sri Lanka. In the dry zone, Russell's viper bites have been more common than hump-nosed viper bites for a long time. Interestingly, we have observed an increasing trend of hump-nosed viper bites in Anuradhapura surpassing Russell's viper bites. This was more prominent during the period after COVID-19. The rising hump-nosed viper bites corresponded to the rising number of snake bites in home gardens, probably due to increased home gardening during and after pandemic. Russell's viper bites mostly occur in paddy fields, and the decreasing number of Russell's viper bites may be due to decreasing paddy farming. This may have resulted from multiple socio-economic factors during the pandemic and post-pandemic period, and also due to increased mechanization of paddy farming in the region. We published this study in journal Toxicon. President, Council, and distinguished guests. Timely administration of antivenom is the mainstay of treatment for snake envenoming worldwide. Antivenom contain polyclonal antibodies of animal origin developed against snake venom. Although antivenom are life-saving, adverse reaction to antivenoms, particularly acute reactions, are well-known problems in snakebite management, and they need prompt intervention. This includes pre-medication and treatment with adrenaline, steroids, and other supportive care. Patients should be closely monitored for anaphylaxis during the antivenom infusion and managed according to the severity of the symptoms. In Sri Lanka, Indian polyvalent antivenom is used to treat patients who are envenomed by Russell's viper, Indian great, cobra, and saw-scale viper, and it is known to cause acute adverse reactions frequently. Similarly, antivenom is also known to cause delayed adverse reactions such as serum sickness. Serum sickness is a type 3 hypersensitivity reaction that develops following the administration of heterologous follin protein or serum. Symptoms typically appear 5 to 20 days after antivenom administration. I was able to contact 521 snake bite survivors 3 weeks after the snake bite. Of them, 98 patients were treated with Indian polyvalent antivenom. While inquiring about the new onset of health issues after hospital discharge, I also asked about the development of features suggestive of serum sickness. To this end, we employed a telephone interview questionnaire from an Australian study to assess the occurrence of serum sickness in patients given antivenom. We define serum sickness as the presence of 3 or more symptoms including fever, chills, arthralgia, myalgia, rash, abdominal pain, nausea, vomiting, malaise, and headache during 5 to 21 days after snake bite. The median dose of antivenom given for these 98 patients was 20 vials. 92% of the patients had received pre-medications for antivenom, but still 68 have developed acute adverse reactions, including 19 developing severe anaphylaxis. However, only 4 patients met the definition of serum sickness at review. Hence, serum sickness does not appear to be a major health concern in using Indian polyvalent antivenom in Sri Lanka. We published these findings in Clinical Toxicology Journal. President, Council, and distinguished guest, after reviewing close to 900 patients prospectively, we understood that the majority of the snake bite patients in Anuradhapura leave the hospital with unresolved health problems, mainly following viperine bites. Hump nose vipers are the main culprit. Patients attend both allopathic and indigenous medical practitioners seeking treatment for these health issues after hospital discharge. However, only a very small proportion of patients develop permanent local effects, which is relatively minor in nature. This is largely due to the type of snakes involving in envenoming in Sri Lanka compared to sub-Saharan Africa and Latin America, where most snakes cause severe local tissue damage. With time, patients who were severely envenomed experience medically unexplained problems. We also found that snake bite doesn't seem to be contributing SINAC. It is eye-opening that among the snakebite patients who were discharged from the hospital, 26% of the patients at 3 weeks and 14% patients at 3 months continue to suffer from unresolved local effects after snakebite. This cannot be neglected. So in essence, we need to focus on the patients who were discharged after snakebite to provide continuous care for the problems they continue to suffer, such as persistent local pain, swelling, unhealed wounds, and other complications as early as possible. We need to educate them on the natural history of these symptoms while providing supportive care such as physiotherapy. This enables them to get back to their livelihood sooner. Surgeons, psychiatrists, and other professionals, including physiotherapists. For the last 4 months, we have provided care for over 100 patients who were having unresolved problems following snake bite. Finally, a case we need. A 27-year-old man was bitten by a hump-nosed viper on the index finger of his dominant hand while farming. The image taken for the Anuradhapura snake bite cohort on admission with the snake specimen on its with the snake specimen and is on the left. After 12 hours, a hemorrhagic blister appeared at the bite site, which later progressed into an ulcer that required a wound toilet. But after discharge from the hospital, the patient was lost to follow-up. Later, he presented to our clinic and was found to have lateral deviation and contracture formation of the distal phalanx of the bitten finger. Further, he was unable to flex the proximal interphalangeal joint due to prolonged immobilization caused by persistent pain. His injury has cost him a lot. He was basically unable to use his dominant hand to carry out even basic routine activities like feeding himself and writing. Because of that, he has missed his Korean language exam, to which he prepared for a long time. While hammering a nail with the hammer held by his injured hand, he accidentally hit the index finger of the other hand and got a fracture. According to him, he was so inefficient in carrying out his farming activities. So the cascade of events pushed him into a vicious cycle. We referred the patient to a surgeon and physiotherapist. After receiving physiotherapy, the patient can flex his index finger now, being able to manage his normal day-to-day activities without much problem. With the plastic surgical intervention, hopefully he will be back to his normal life. President, Council, and distinguished guests, this is an era in which we speak of cutting-edge research into precision medicine and complex intervention tailored to individuals. However, knowledge generated through the basic research using our clinical materials and its translation into simple interventions accessible to patients could still make a significant difference. That is the lesson I learned in my research journey. I would like to thank my parents, my father Sunil Vaidyanatha and my mother Leela Vaidyanatha, for bringing me into this world and shaping me into the person I am today. For their sacrifices, love, and unwavering support, I am eternally grateful. And next, I would like to thank my husband Anjana for helping me recognize my strengths, guiding and encouraging me towards growth, and also for establishing Anuradhapura Snakebite Cohort, which has become a platform for many researchers, facilitating many research studies. We got to know each other during the Theravada Medical Exhibition in 2003, in which both of us were allocated to snake bite and poisoning stall. Also, I must thank my little son Kemitha for being my constant motivation and the happy pill. And I must thank my brother and sister and their families for the continuous support, love, and care they have given me. Professor Sisira Siribaddana, my PhD supervisor, the fatherly figure in my academic career, and our go-to person whenever we have a problem. Thank you so much, sir, for nurturing me to become a better researcher and an academic. Then I must thank the other PhD supervisor, Professor Jeff Isbister from the University of Newcastle, Australia, for guiding me and showing me the new avenues of snakebite research. And he provided all the fundings for my PhD through his NHMRC grant, and his frequent visit to Anuradhapura always motivate our entire snakebite team to work even harder. Then I should greatly appreciate the SACTRAC for providing logistics for the Anuradhapura Snakebite Cohort, and Mr. Umesh Chaturanga, the SACTRAC Anuradhapura Center Coordinator, for supporting us to carry out our studies hassle-free. Then I want to extend my gratitude to all the clinical research assistants and Mr. Arunasiri and all the study participants. Also, I need to thank Professor Kosala Veerakorn, Dr. Supun Medasinghe, our Dean, Dr. Janaka Pushpakumara, the Department of Parasitology and the Department of Medicine for their invaluable support. Thank you.
Thank you very much, Madam, for your incredibly valuable insights. We hold this conference in a time when our city and indeed country as a whole has experienced and is currently recovering from one of the worst natural disasters in recent times. The University of Peradeniya specifically has been significantly affected as a result of the overflow of the Mahaweli Uving to the Ditwa cyclone and has as a result incurred damages and losses amounting to billions of rupees.
We wish to draw attention very specifically to the Faculty of Veterinary Medicine and Animal Science, a fellow branch of healthcare that has previously, in times of our need, very graciously come to the aid of hospitals in and around Kandy and Peradeniya, providing us with crucial PCR testing capacity during the worst stages of the COVID-19 pandemic. Tragically, the very equipment used for this life-saving efforts has also been destroyed.
In light of this, the Kandy Society of Medicine has conducted a humanitarian campaign to draw funds for the rebuilding of our country and community. And it is our humble privilege to pledge a sum of 1 million rupees from this fund to the Faculty of Veterinary Medicine and Animal Sciences, University of Peradeniya, with the specific purpose of rebuilding and renovating the wild animal treatment, management and rehabilitation unit of the Department of Veterinary Clinical Sciences, in hope that they will be able to rise from this tragedy stronger than ever before.
We would like to invite Professor Ashoka Dangolla, representing the Faculty of Veterinary Medicine and Animal Science, to receive this donation from the President of the Kandy Society of Medicine, Professor Arinda Dharmapala, and the Treasurer of the Kandy Society of Medicine, Professor Chaminda Kandoda. Thank you very much, sirs. To bring the proceedings of the inauguration ceremony to a close, this invitation goes to Dr. Asela Ratnayaka, Joint Secretary of the Kandy Society of Medicine, to deliver the vote of thanks.
Good evening, ladies and gentlemen. So I'm deeply honored to have been entrusted with the duty of proposing the vote of thanks at this auspicious inauguration ceremony of the 48th annual academic sessions of Kandy Society of Medicine. At the outset, I extend our profound gratitude to Professor K.B. Galkatia for graciously accepting our invitation to be the chief guest at this pinnacle academic event of KSM. Sir, your esteemed presence and words of wisdom have added immense value and distinction to this occasion, and we are truly grateful. I also wish to my heartfelt congratulations and sincere thanks to Dr. Subeda Vaidyanatha for being the prestigious KSM Orator 2026. Your oration, Life After Snake Bite in Rural Sri Lanka, Lesson Learned and Way Forward, provided a powerful insights into a critical yet often overlooked public health issue. Thank you for enriching our academic program so meaningfully. I take this opportunity to sincerely thank our distinguished invitees for honoring this inauguration ceremony with your presence. Professor Saman Nanayakara, the Dean, the Faculty of Medicine, and Professor Shyama Bannayaka, Dean, Faculty of Dental Sciences, Dr. Sampath Ranavira, Provincial Director of Health Services, and Dr. Chandana Vijay Singh, Regional Director of Health Services. And Dr. Arjuna Tilakaratna, Director General of Health Services MS1 and the Director Teaching Hospital Peradeniya. Dr. Iresha Fernando, Director National Hospital Kandy, and Dr. Veerabahu, Director, Sirimao Bandanayaka Children's Hospital. Your presence today signifies your respect and commitment to the advancement of medical academia. Dear past presidents of Kandy Society of Medicine, a round of huge applause for your continued unconditional support from the time you led this prestigious organization to the present day. Your physical presence at today's inauguration is a great honor to us all. I am certain that you must feel a deep sense of pride in witnessing the continued growth, vibrance, and glamour of the KSM, built upon your invaluable contributions over the years. A very special word of appreciation goes to Professor Arinda Dharmapala, the President of the KSM for 2025-26, the captain of our ship. Although I had to hold the port few occasions due to his voyages, he steered the society with vision and strength, upholding all traditional events of the KSM, successfully delivering both academic and social milestones. Despite the challenges posed by the tragic Ditwa cyclone, you led the society with resilience and compassion, initiating several humanitarian projects to support affected communities. Your leadership and guidance in ensuring a success of 48th annual academic sessions will undoubtedly be recorded in the proud history of the Kandy Society of Medicine. I also extend my sincere thanks to the key office bearers and entire KSM Council for 2025-26 for your dedication, unity, and tireless efforts. The smooth execution and outstanding quality of this academic program are clear reflections of the immense work you have accomplished together as a one-unit team. I would be remiss if I do not acknowledge a few individuals who served as the strong pillars behind this success. Dr. Ranmini Vijayakon, one of our social secretaries, deserves a very special thank, and your unparalleled contribution, arranging everything in a meticulous way from inception to final execution of the program, including seamless coordination with the hotel management and all stakeholders. Your commitment and attention to detail are truly commendable. I think we truly lacked sufficient words to thank Dr. Andrew Rajapaksa for his unwavering and unparalleled contribution in providing digital, technological, media, and printing support. The impressive visual appeal and professional outlook of this event stand as a testament of your remarkable work. To Dr. Krishna Pradeep and the members of the Abstract Committee, we extend our sincere appreciation for undertaking one of the most demanding tasks with excellence, reviewing every phrase and the word to select 174 abstracts for oral and poster presentations is no small achievement. Your efforts have added true scientific values to these sessions and honored a genuine work of our researchers. I would like to take this opportunity to sincerely acknowledge the invaluable contribution of all the resource persons and coordinators to ensure the successful pre-Congress workshops, which were one of the highest number that we conducted during our annual academic sessions. I would like to take this opportunity to offer a special note of thanks to the chairpersons and the resource persons for graciously accepting the invitations to share your expertise and updated knowledge at the 48th annual academic sessions of KSM. Your efforts have greatly enriched the academic value of this event and will continue to inspire excellence in our community. The KSM photography exhibition, as you all know, an integral and much loved component in our annual academic sessions, provides a platform to showcase the photographic talents of medical professionals and their family members. This unique attraction stands solely on the perseverance and dedication of Dr. Kavinda Amarasinghe. We salute your tireless efforts and passion. We are truly fortunate to have our sponsors, the Gamma Interfarm, as the premier sponsor. Our heartfelt thanks also go to Seven Hospitals, Asiri Hospitals, Kandy, and Farm Evo Private Limited for their generous contribution as gold sponsors, along with all our silver and bronze sponsors. Your valuable support ensured the financial strength needed to conduct this high caliber academic event with resounding success. The KSM is a vibrant organization with continuous activities that require efficient coordination. Mr. Pasindu Fonseca, our KSM Office Secretariat, deserves a special appreciation for his silent yet highly effective handling of administrative and event-related matters. So before concluding, I wish to thank our compeers and budding young doctors and pre-inters of your enthusiastic volunteer support and active involvement in organizing and executing many crucial tasks. Finally, our sincere gratitude to the management and the staff of Grand Candian Hotel for your warm hospitality, professionalism, and unwavering support, making us feel truly at home. Once again, I thank each and every one of you who contributed to the success of this event and your participation. With that, I conclude the word of thanks and warmly invite you all to enjoy the fruitful scientific sessions over the next 2 days and the annual dinner on Friday. Thank you very much.
Thank you, sir. As the evening settles over the hills of Kandy, our formal proceedings of the inauguration ceremony of the annual academic sessions of the Kandy Society of Medicine have come to a close, but the conversation is only just beginning. We leave tonight with our minds sparked by the vision of a healthier Sri Lanka and our spirits lifted by the fellowship in this room.
We look forward to seeing you in the coming days of learning and celebration, which will include multiple symposiums on pertinent themes, as well as oral and poster presentations by aspiring visionaries, and hope that you join us as we showcase the advances that are shaping medicine in our wonderful city and country.
We also warmly invite you to join us for a night of hospitality and fine company with a cocktail dinner that will be served in the ground floor foyer as we toast to the 2 days of discovery that lie ahead. Ladies and gentlemen, let us now rise in respect as the ceremonial procession leaves the hall. Good night.